Good evening, everyone, and welcome to the third in our Phronesis series. This is a journal club that's been designed to discuss musculoskeletal and hand surgery papers, and the idea is to involve an active discussion between plastic and orthopaedic surgeons. This evening is hosted by ICOPLAST and PLASTA. There is going to be a chance for a discussion afterwards, so please use the question and answer function, not the chat. Thank you. I'm delighted to introduce David Izadi, who has put together tonight and got an amazing panel to discuss Chuck Goldfarb's paper. David has actually finished his training this week as well, and he's the outgoing TIG at the Pulvertaft Hands unit in Derby, UK, and he's about to start as a consultant in Coventry, again in the UK. Over to you, David.
Thank you very much, Rebecca, and thank you to all of our attendees for signing on this evening. Thank you in particular to our international faculty for agreeing to give up this time this evening. So this evening is a pleasure to introduce the senior author of tonight's study, which is published in the American Journal of Hand Surgery, Chuck Goldfarb. He is the Executive Vice Chair of Orthopedic Surgery at Washington University and Chief of Pediatric Orthopedics and Co-Chief of Hand Surgery. We have also Giele Arrowsmith, who is my mentor, my friend, and she has been wonderful to me in the last year. So she's one of the consultants at the Pulvertaft Hand Clinic, where I'm currently based. Next, Stephane Guero. I had the pleasure of meeting Stephane during a FESH fellowship at the Institut de la Main. He's one of the founders of the Institut de la Main, and he sits on various executive pediatric European bodies for hand surgery. Stephen Hovius, he is the Emeritus Professor in Rotterdam. He works currently part-time, and he is a world authority on congenital hand surgery.
Some more experts on the panel as well. Marybeth Ezaki, who works at the Scottish Rite Hospital in Texas, is joining us today from Colorado. Henk, Giele, Professor of Plastic Surgery in Oxford, UK. Giele Smith, who works at Great Ormond Street and Chelsea and Westminster in the UK, formerly worked where we are here at Stoke Mandeville. And Kirsten Oestreich from Children's Hospital in Birmingham.
Great. So at this point, we're all going to mute ourselves shortly, and I'm going to invite Giele Arrowsmith to start off by introducing a interesting case of a simple, complete syndactyly. Over to you, Giele.
Thank you. Okay, so hopefully you've all got my screen.
Giele, we can see your screen. Thank you.
Great. So I'm going to present this child who's a little boy, and I first saw him when he was a month old. And as you can see, although David said he's simple, complete, he's actually slightly unusual because it's his fourth web that he has syndactyly on, and it's on both, it's bilateral, both hands. And this is another view of his hand. And as Kirsten quite rightly said when I showed her the slides, has he got something else going on? And is it oculodentodigital dysplasia, which is a genetic mutation which commonly gives you a fourth web syndactyly release? And that's absolutely correct. He saw the genetics team, and that's what he has. So when I first saw him, I was concerned because his ring finger's closely tethered to the little finger, and you can see the length discrepancy. And what I decided to do was an initial distal release using Buck-Gramco type flaps with another little bit of flaps around here to loosen off the distal phalanges of the two fingers. And we did that when he was about 3 months old. And this was his, by the time we did it when he was about 6 months old, and this was him about 3 months after the initial release. showing the improvement in the position of the ring finger in particular. And if I just show you now what it was like before and what we achieved by doing the distal release, see how much more length we've got in the ring finger and how much straighter that is now. The reason we did an initial distal release was because I was concerned about his ring finger, but also he was so small, I was a bit worried about going on and doing a full release, which would be interesting to hear the rest of the panel, whether I could have waited a bit longer and it would have been fine, or whether I should have just done a full release straight away. But this is what we did. And then when he was about 1 year old, we completed that with a full release. I like using a large web flap after Henk, and I like using quite narrow flaps like the open Summerlad technique. I like these because they're a slightly sloppier fit when you're draping them around, and I like leaving smaller bits of gaps to heal up. So this is him 3 months after the full release, and you can see the donor site scarring along here from the dorsal web flap, and then healing up along the inner borders of the digits, and reasonable web spaces on the palmar view. He maintained this for about 3 to 4 years, but was getting a little bit tight on the left hand, so had a little bit of a Z-plasty release along here to loosen that one off. And just to show you his x-ray, so as part of his condition, he does also have very small middle phalanges, but only on the ring finger, on the little finger, sorry. This is the final photographs of him. By the time he's 8.5 years old, we've still got a nice web space. And this is his mum, and with her ring finger in view in the shot, showing that she also had the 4th web syndactyly on both hands, and she has a milder version of the ocular dentodigital dysplasia syndrome. This is what his scars look like. So he does have visible scarring on the dorsum of the hand when his fingers are closed, which is a consequence of having a dorsal flap trying to avoid a skin graft. The zigzags in the fingers are pretty well hidden when his fingers are closed. And finally, just to give you an idea of what he looked like as time went on and his scars settled and his fingers grew. Excellent.
Thank you very much, Giele. So next up, Chuck Goldfarb is going to talk to us a little bit about his paper and some of his ideas of treating syndactyly. Thanks, Chuck.
Sure, it's my pleasure. Let me share my screen. So thank you so much for having me as part of this discussion and reviewing our paper. We first learned of the use of hyalomatrix from Professor Landy in his earlier publication on this topic. And actually, I discussed this with Dr. Landy at Stephen's World Congenital Symposium meeting in Rotterdam a few years back. And that led us to want to study this ourselves. And the results are and will be presented. Let me give you one quick case example. I'm here in the United States in St. Louis, Missouri, pretty much in the middle, and I'm fortunate to work at 2 wonderful children's hospitals. I want to briefly, and this is hopeful, I want to briefly invite you all to attend the next World Symposium on Congenital Malformations that I'm co-hosting in Minneapolis, which is scheduled for May of 2021. We are all hopeful that we will have moved on from the coronavirus. Whether that's reality or not, time will tell. But I hope we can meet, and I look forward to it meeting with you. So briefly, I'll present a case of an 18-month-old otherwise healthy male with syndactyly. It's isolated cutaneous, although the nails are separate in distinction to the case we just saw. Right hand only, middle ring finger. So the most common presentation. You can see this is my typical release pattern. This is as described by Adrian Flatt, although one difference is I don't have a straight line incision because we know that increases the tension. So I break it proximally and I allow an interdigitation on the palmar side. You can see my a little bit deep as planned, coming back a little further into the palm. We had an uneventful surgical reconstruction, and you can see, as would be expected, there are several areas of skin deficit, as we all know, on the medial side of the ring finger and the middle finger. Our tourniquet time was about 55 minutes. I typically apply a long arm cast. I'm going to go forward one slide. You can see here that we used Hyalomatrix instead of full thickness skin graft to cover our deficits. And that's what it looks like once applied. I use a long arm cast for 3 weeks, and then the patient comes back to the clinic. The silicone, the semi-permeable silicone, is removed, and it's quite easy to remove at that 3-week visit. And hopefully and presumably the skin will have healed over the top by that point. I'll show you a slide that suggests that's not always the case, but typically it is. And then I use therapy as needed, occasionally with an otiform spacer to put some pressure on the deep web space. Here's the child about 6 months later. You can see there's a little prominence of the scarring, perhaps more notable than some that we see, but a nice deep web space. So as I consider Hyalomatrix and its use in my practice, I find several benefits. First, it avoids an additional incision, and it avoids the need for harvesting skin graft. Surgical time is markedly reduced, and in general, we've been very happy with the aesthetic outcomes. It's straightforward, and it has been really made the process of syndactyly reconstruction more enjoyable at our hospitals. I will say that a small percentage of patients will experience a hypertrophic granuloma and prolonged healing time. And anyone in the audience who has done this technique may have seen this. Interestingly, we did not report that in our manuscript because of our chosen population did not experience that complication. But I'll show a picture of this. But if you see a hypertrophic granuloma, it's relatively easy to treat. We typically use either silver nitrate or betadine soaked gauze. And once that's been handled, the skin heals nicely over the top without a problem. We've never had to perform a revision surgery, and we believe using a little larger sheet of Hyalomatrix may minimize this risk. So this is an example. I wanted to share it with you. This is one of the more severe examples that I could provide with you. And so you can see the hypertrophic granuloma, but this was at 3 weeks after surgery. 3 weeks later, it's completely healed. So it is a little frightening when this happens, but I think aggressive treatment of the hypertrophic granuloma leads to excellent outcomes. And ultimately, this child looked really good when we were done. So that's all I had to share. I find this technique to be helpful. I will continue to use it. I don't choose to use it for every patient, but I think it's a good option and a good tool. It's inexpensive. And again, it speeds the surgical time and saves a surgical incision. Thank you.
Great. Thank you very much for presenting your technique. This brings us perfectly onto tonight's paper with Chuck as a senior author, Outcomes of Pediatric Syndactyly Repair Using Synthetic Dermal Substitutes, and published in the Journal of Hand Surgery American volume. In brief, the aim of treatment is for separation of fused digits. We want to create a normal web space and improve both the function and the aesthetics. And this is usually done between 6 and 24 months. The traditional options, as we've heard, have been either using grafts or graftless technique, as Jill Arrowsmith demonstrated earlier. There are several pros for both and a few cons for both as well. But essentially for the grafts, they're reproducible. They can achieve full release, removing all the tension, and they are relatively reliable. The graftless technique, you are utilizing local tissues. You've got good color match, less hypertrophic scars, short anesthetic time, and you have a lower instance of web creep and revision as per the literature. The alternative, which Chuck has tried to expand on from the established literature, where Integra and Matroderm were initially used, is the Hyalomatrix PA. In Chuck's paper, he showed that the Hyalomatrix PA the hypothesis was they would produce favorable objective outcomes measured by a low Vancouver scar scale. To do this, the paper looked at patients prospectively from December 2015 to 2017 who were English speaking and were able to complete follow-up. 16 patients were included at a median age of surgery of 27 months. Majority were male, but there were 2 male dropouts further down the line. The inclusion criteria, 12 in the study were included after surgery, and 4 patients recruited before surgery. A total of 23 syndactylized webs in 16 patients were included. 14 incomplete, 5 cutaneous complete, and 4 were complex. 5 of the incompletes were revision surgeries performed as a result of creep after the initial surgery. 2 patients were affected by amniotic constriction band, and 3 patients had diagnosis of Syndactyly. Involved web spaces included the 2nd, 3rd, 4th, and the central rays. And the procedure, the technique, has been demonstrated a little earlier. Postoperatively, the patients were described to be going into a cast for 3 weeks. At 3 weeks, the cast and the top layer were removed to allow for the bio material to be integrated into the skin. They were seen by hand therapists, and they had dressings for a period of 8 weeks afterwards. They followed up the patients at 6 to 8 weeks, 3 months, 6 months, and 1 year after surgery. And they evaluated scar appearance, digital range of motion, web creep evaluation, scar appearance as per Vancouver scar scale, and surgical site appearance as per the visual analog scale. The results, 14 of the 16 patients were included. 2 male patients were lost to follow-up. Final follow-up was 12.9 months average. The web creep, only 3 out of 21 had web creep. 16 out of 21 had no creep. 2 out of 21 had web creep thickening without advancements, and 3 out of 21 had some advancement of the web creep. The Vancouver scar scale, where the lower end of this scale is a favorable outcome, ranged from 0 to 5, with, I'm sure you know, the range of this Vancouver scar scale is up to 14. The surgeons and the parents independently scored the visual analog scale between 0 and 10, where 10 is excellent and 0 is poor. So the results generally were very good. There were no major surgical complications. No patients required web revision at 1 year. One of the grafts, as Chuck showed in one of his complications, was lost but healed by secondary intention, and no reoperations within that time period. So the pros of this technique are that 2 experienced surgeons were performing the operation. Excellent results were reported as per the paper. No major complications noted. They use validated tools for the outcome, and it's a novel technique with no donor morbidity, shorter anesthetic time. The critical appraisal of this paper is I try to look at everything systematically. Did the study address a clear focused issue? So the hypothesis was clear. The population group was variable, so the age range was between 5 and 8 years, and the amount of skin available and the size of defects, I guess, would vary depending on the age of the child. There wasn't a power calculation, multiple outcomes, so why the Vancouver scar scale was used as a primary outcome. Selection bias, so there was no blinding of the patient to the surgeon. There was no control arm. And again, a lot of these limitations have been discussed in the paper very openly, but I will repeat them for the sake of the critical appraisal. Native English speakers only. Now, this brings up the question, could this be different with people who are not difference in these patients? There was no data on ethnicity. Were patients given the option for other treatment types? The majority, 4 out of 23, were incomplete syndactyly releases. Again, this is analysis and drawing conclusions from a very heterogeneous group of patients. There was discrepancy in the recruitment at pre-op and post-op. So some were recruited pre-op, some were recruited post-op, which brings in, could this have a selection bias by the surgeon question? Measurement bias. So the people measuring were not blinded. Again, this is very difficult to achieve because the surgeon is following up their own patients. The operating surgeon was performing the outcomes. It was unclear of the level of training or expertise of the therapist who was also measuring the outcomes. It was unclear if this same therapist was doing all of the follow-ups and all of the cases. Can the pliability and scar height be accurately standardized or measured on digital imaging? And again, Chuck refers to this in his discussion of his paper. Measurement tools can be subjective, sorry. No mention of the range of movement measurements, again, active, passive, and total range of movement. The reporting bias, so there was no disclosure of differences in the outcome in child with the failed graft. There was no disclosure of whether there was any financial involvement or sponsorship of the study. No disclosure where measurements were in, whether the measurements were in the age range of the patients. 3 out of 21 cases had web creep, which were clinically relevant. Unsure, it hasn't been elaborated what's clinically relevant. There was no disclosure of whether the results were different between the two operating surgeons. Relatively short follow-up period of 1 year. And again, this has been discussed in the paper. There were differences between, were there any differences between early and later cases, i.e. was there a performance bias? There was no data on the length taken for grafts to heal, and no data on the range of movement as a marker for the hand function. So the claim that is made in the discussion is that initial healing by the reconstructive technique would be seen within the 1 year. So anything related to the follow-up should be seen within 1 year, but there's no evidence for this statement. The cost and availability of a synthetic dermis has been mentioned at $350 per patient, which can be expensive for low-income nations. So in summary, this is a valuable addition to the literature. It is one of the largest published series for synthetic dermal substitutes in syndactyly release. Overall, there were excellent results reported. Further studies are required to compare outcomes, for example, grafts versus synthetic dermal grafts, where the surgeon and the assessor can be blinded, and that will give a stronger evidence base. So thank you. And Chuck, I thought the paper was excellent. I'm sorry to have to critically praise it. So I would like to invite you, first of all, for any comments, please, Chuck.
Thank you. You know, this type of work is clearly limited, right? This was not an attempt to provide a prospective randomized trial, which is really difficult to do in kids. And it is limited. This type of work is not going to be groundbreaking, but it's meant to share and also to build upon Professor Landy's work and show that another center found similar successful results. We continue to use this technique. It's not perfect, but we like it, as I mentioned. Your critique of the paper is completely fair. There's no financial bias. We're not working with the industry. And I have nothing personal to gain by the findings that I'm sharing. And ultimately, the difficulties of congenital hand research are being remedied around the world with a number of registries which have come into being, including one that we're working on in the United States. And so that's the hope for the future, using large numbers of patients to investigate techniques like this. So I appreciate the review and your kind comments. It is a limited paper, I recognize that, but it already has been successful in generating conversation, as we can see by the panelists and by the attendants at this discussion. So thank you.
Thank you. So the next section of the evening is where we invite all of the panel members to talk to us briefly about their thoughts on the treatment of syndactyly. And we're going to start with Stephen Hovius, please.
Thanks very much. And I hope you can see my screen.
Yes.
Fine. Well, this is a simple, nearly complete syndactyly, and the release would be, to my mind, mostly always with a dorsal flap. And Henk has discussed it, but it's basically from an Indian guy who I just can't speak his name out properly, so I won't do that. And basically using a dorsal way, so you have a slope, and using, if it's a small defect and you have good pulp, then I would just leave it or close it with a triangular flaps as possible. And if you have a more fused, then I would use Bekramko flaps. This is an example where I varied this sort of design quite often, but used always, in the beginning I used the Bekramko flaps for the interdigital space. I like this concept better. You have the disadvantage of the dorsal scar, but you have the advantage of having skin not scarred inside the digital space, but at the sides. So you have less creep in those cases. And as Chuck has already pointed out, go a little bit deeper because you're sure you're going to have a little bit of creep. I think 1 year follow-up, as has already been discussed, is very short. And I did, so you have to look at it for a longer time, because especially at puberty or at growth spurts, then you have the possibility of having scar tissue becoming more evident. Just something about, shall I go on with Apert syndrome or shall I stay here?
We've got time, carry on.
Okay. As I know everybody would discuss syndactyly, which is the most common one, but not, of course, Apert syndrome. I would like to discuss very complex cases where we did research on, and those are the Apert syndromes. You have different types. The type 1 has a small finger separate and the thumb separate. Type 2 has all the fingers syndactylized, but with the thumb, the clinodactyly, and separate. And as you can see here, there are stiff fingers at the PRP joint and hardly DRP joint movement at all. Some have, and you can see also that you can use either a lot of separation ways to do these because the fingers are not bending at the PRP or DRP joints very well. So here's a different technique can be used. You can get quite acceptable results as long as the fingers are rather straight. And I know Henk has showed me, Henk Giele has showed me that you can do it all in one. And we have done 2 hands in one operation to save the amount of operations for these kids, because they also have a lot of operations on the craniofacial side. Here's a very complex one with a nail wall reconstruction. This is a type 3 hand. And I won't say the common word for it because I think that's quite denigrating for the child. But you can see here that these kids, I think it's one of the only reasons to operate very soon. And why? Because before the craniofacial operation, because the infected nails make the child rather sick and not well, at least not well. And as soon as you've done the nails, they really get more clear and less sick. So that was for the craniofacial guys and girls a better an advantage to do that in the beginning. Nearly all the other syndactylies I would not do before 1 year, especially not because of all the discussions on anesthesia. Then if you have a complex case like this, then I wouldn't dare to do a separation of all the rays at the same time. But try to do it in two times, and having the small finger and the thumb out at the first instance and getting the nail more. It's difficult to see in these pictures, but actually this little flap here survived completely in two ways, as you can see here, just to get a coverage for the pulp. And here's the second phase, the Bekramko flaps. and the separation. And you can see here we have a free finger block and a thumb.
You're running out of time now, just to let you know.
Okay. Okay, thank you. And this is just to show you a difficult case and with a longer follow-up of 60 patients we've done in 30 years. And thank you for that. I have research outcomes later on, but I will leave that because of the time.
Thank you. Thank you very much. Next up, Stephane Guero, please.
Thank you. Hi, guys. Thank you for giving me the opportunity to comment what I usually do for a simple syndactyly. I'm very reluctant to have some scars on the dorsum of the hand. That's why I prefer to have a short flap. I use the omega flap, and it's avoid to have this scar running over the metacarpal head. And it's the social part of the hand. That's why I would prefer to have a shorter flap, a dorsal flap always, but then I have a defect, of course, and I need a skin graft. That's why I'm so interested in the Chuck paper, because I remember many years ago, Professor Landy was in my symposium in Paris and presented his first result, and I was maybe a little afraid of a conflict of interest at this moment. So I'm happy that another team can confirm the good result. And it's one of my dreams to avoid grafting. At the moment, I prefer to offer my patients, my children, the best as I can. So I'm still very conservative, and I prefer to use full thickness skin graft until we have proven that we have some other possibilities. Maybe yellow matrix would be very interesting. Some teams in Paris have tried the matriderm. It's nice too, but the problem is the economic problem. The price of the matriderm is really high, and we cannot offer this in different countries, and especially even in the private activity in Paris. We cannot afford this, and so only in the university hospital they can have for, I mean, it's just samples who are given by the laboratory, and as long it's free, it's okay. But then when you have to pay, probably the budget of the hospital will be closed, and you can't use matriderm anymore. So at this moment, the best for me, and I mean the cheapest, is the full thickness skin graft. But anyway, maybe in the future I will try the yellow matrix. I can't hear you.
Rebecca, you need to unmute.
Oh, yeah.
Thank you very much.
Okay.
Next up, we're going to move to Marybeth Ezaki.
Marybeth, can you start again?
Okay, thank you so much for allowing me to, or inviting me to participate in seeing so many good friends. I am a bit of a dinosaur because I still use full thickness skin graft, because I think there is a true defect, and I've been tempted by the techniques that would allow me to do a syndactyly reconstruction without any graft, but I think to cover the defects, you really do need that skin graft. Syndactyly reconstruction, as I've told all of my residents and my fellows, is probably the fiddliest of the operations. Every single detail makes a difference, and if you mess up on any one of them, you're going to have a poor result. And probably one of those details is actually harvesting that skin graft. And I only sort of halfway joke that I've skinned a number of babies to get to the point that I can take up a skin graft rather quickly. So that was something that I was really comfortable with. Now, the reason that we take a full thickness skin graft is because it doesn't shrink. As we have all been taught, a split thickness skin graft will contract, it will take the size of the wound down. But a full thickness skin graft should not shrink down. And so that's what we're trying to get to. If we can come up with something that gives us that coverage without shrinkage of the area, then we've really hit on something. And I'm not convinced that any of these dermal substitutes, even the Hylometrics, really does that. And if you look carefully at the photographs and the images that have been published along with it, you can see where the photograph of the matrix as it's applied at surgery is a whole lot bigger than the little tiny bit of the graft that you see in the final photographs. I agree that the cost and the availability is going to be a limitation. But I think it was an excellent paper to get us thinking about these things and to try to keep pushing so that we have a better way of taking care of the kids with the syndactyles. So that's it. Thank you.
Thank you. Next up, Henk Giele, please. If you can unmute yourself, that'd be great.
Am I unmuted?
Lovely.
Okay, so my screen share doesn't work, so I'm now videoing my screen. So my techniques that I use a dorsal winged flap, because when your rectangular flap goes into the web space, it leaves two triangular defects, that patches that you have to put your full thickness skin graft or your dermal matrix in. But those triangles can actually be taken with the rectangular flap, so that your rectangular flap becomes a hexagonal flap, with the base of the hexagon being the flap just there, as you can see. So that when the rectangular flap goes in, it takes the two triangles in with it, and that closes the defect that you would otherwise have to put your graft in. So there's the drawing. I do the commencement of my flap a little bit distal to the metacarpal head dimples, and the length of the web space. I do larger Zs down the finger, and I later on did a back cut, as you can see there, into the advancing edge of the rectangular portion of the flap to allow a triangular palmar aspect to inset, so that the inset wasn't a straight line, but it was it becomes a W. So there's the flap raised, inset into the defect. You see that the palmar V insetting into that inset there, and then you close the rest of the defect, and the donor site of the triangles on the dorsum closes directly. You can see the web space now has that V that prevents creep. Here's another example there, and that was a incomplete, and that's the longer term outcome. Now the point about the dorsal scar here is that the dorsal scar is not over the metacarpal heads, it's over the mid or proximal third of the proximal phalanges. So actually from the dorsum of the hand, there is no scar. The scar's on the back of the fingers and not visible, and if you wear a ring, for example, it's hidden. It's also useful for adults, so you can use it when there is no skin laxity as you would get in a child. So here's a guy who had his syndactyly treated when he was over 30. Do the same thing using the dorsal skin laxity to provide the skin, to replace it, the separation, the inset, closure. Don't worry about the small defects, and this is the outcome after a few weeks. And those scars are not visible from the dorsum of the hand, they're only visible on the back of the fingers. A nice web. And it's also used for toes. Toes are often not separated because of the problem with doing a full thickness skin graft or other grafting, but actually you can use the same technique to separate toes without grafts with an acceptable result. Thank you.
Thank you very much. Giele Smith, please.
Hi, thank you for having me. I'm going to feel like a bit of a dinosaur as well. I don't see many simple syndactyly. Most of mine are more complex, and I'm quite a simple person. I don't like scars on the dorsum of the hand, nor do I particularly like them on the dorsum of the finger if I can avoid it. So I still graft. I have tried dorsal flaps, I've tried volar flaps, but I like a triangular dorsal and a triangular volar flap that interdigitate. That makes it very easy if you're an amateur. I'm not saying I am, but it makes it much easier because the pattern of zigzags you're going to make is going to be the same both sides. If when you get to the point that you're separating, you find that you've got a neurovascular bundle that's in the way and you really can't release it as far as you think you can, you just don't have to overlap quite so much. You can overlap to there. If you've been a bit daft and you've made your flap too short, you can make it reach by not overlapping so much, whereas otherwise you're in real trouble. Now, okay, most people perhaps are much better at these things than me and they can manage to get it right first time, but I have a lot of complex patients where I can't. If they've got joints, then I do zigzag scars like everyone else, but I do quite small zigzags, like Giele said before. If they haven't got joints, then you can do a straight line scar because, you know, you're trying to stop contracture. I haven't used the skin substitutes. I heard the original work from Landing, and I was hoping to hear, because he started in 2008, and I was waiting for the publication by Lorenzo or Landy about their longer term results, because of course that would be 12 years down the line. It's very interesting, Chuck's paper, to see some results from someone else, but obviously the median age of operating was late. It was 24 months. I mean, the case that Giele presented, I'd normally operate 6 months, maybe 7 months old. So that's very, very much different. The size of the hand is very different, as Giele was saying at that point. Follow-up for 1 year. Well, my main web creep is at 8 years. So I would rarely need to intervene before then for a stage 1 or stage 2 web creep. So to have 5 out of 21 with web creep at a year, I would be slightly concerned about that. But saying that, some of those were revision cases. I still use skin graft. I use it either from the upper arm or from the groin, and I've used both. And I often leave, if I don't need a lot, I leave it down to the parents what their choice is, and I go through the reasoning. I do think that you get hyperpigmentation in some patients badly. Most white patients, it's not a problem, but some Middle Eastern patients, it can be a huge problem. And likewise, if they're black. And I'm a little disappointed that Chuck didn't produce data on ethnicity, because I think the colouring and the colour match is one of the things that is most noticeable. The technique I use usually leaves the skin graft in the base of the web, so it's only when you spread your fingers you're really noticing it. But even so, I think that when you have a very dark patch on paler skin, that is very noticeable, and I would really like to know what sort of colour you get in these patients when they're not white. But I think it's a very interesting paper, and I would like to consider doing some once I've seen Landy's results with a much longer follow-up. Anything else I want to say? Oh yeah, healing. Healing was very long in this paper, and talking to Lorenzo, Landy's work, healing's very long. I would expect a simple incomplete syndactyly to be healed at 3 or a maximum 4 weeks, unless I got an infection. If I get that, I'm going to have more scar problems with hypertrophic scar and web creep. And if I'm healed at 3 to 4 weeks, I wouldn't expect that. So I thought 8 weeks was very long. That's probably my comments. Let someone else talk.
Thank you. Kirsten, please.
Yes, thank you for inviting me. I share some of the thoughts of my previous speakers here. An excellent paper, and I haven't used it myself, any dermal matrix. I'm still not a dinosaur yet, but probably trained by a dinosaur, Ruth Lester, and I'm still using full thickness skin graft as well. And even though I'm quite intrigued about your results, I agree with Giele. I was a bit surprised about the length of healing and the amount of dressings, because we leave a dressing on for 2 weeks, we take it off, and most often it doesn't need a dressing at that point. So I think that's a bit of a disadvantage. And similarly, we take the graft from the elbow crease most often, and it's barely visible. So I think from the grafting point of view, I'm not so worried about it. I have prepared a very small presentation. I'm trying to share this with you, how we do our syndactyly release in Birmingham. And let's see if that works. So for us, it's really the philosophy that it's not just a functional procedure, it's actually a cosmetic procedure. Because whatever you leave behind is the really important thing, because people have to look at the hands all their lives. So whatever you do, post-operative, the cosmetic appearance has to be better than pre-operative. The next principle, it should always be like for like. So we heard already the ethnicity is a problem, and color match of skin grafts is a problem. And obviously no hair growth should be on those skin grafts. So you have to be mindful. The next cosmetic principle, you should have almost invisible scars on the hand. And that includes for me, the dorsum of the hand and the dorsum of the fingers really. And producing the anatomical web with an alignment of the arch, I think that's the principle for everyone. And we also acknowledge that there are different techniques needed dependent on the patient profile. And Ruth Lester, who is my sort of mentor, has done a very nice paper on this, which I've quoted here. This is an example of a dorsal, of a palmar flap, where you can see a natural shape of the web has been created. There's only a single scar visible at the dorsum of the hand, and the grafts by all means are needed, but they're actually hidden from the dorsal view. How do I do a palmar flap? I just have a little example here of the drawing. It's a dome-shaped palmar flap to actually create the web. Then I also do narrow zigzag flaps, which then cover very nicely, same as both Gilles have mentioned. And for the tip, either similar, what we heard already, just a little triangular flap, or if it's needed, a book Ramco type nail fold flap. And the grafts you can see in the bottom picture here, they are quite nicely hidden. This again is a result of an outcome from the dorsum and the palmar. At the palmar aspect, you can actually see the skin grafts, but they blend in very nicely. And this is a younger child which had already a release in the fourth web and is now having a same release on the third web. And you can see at the outcome that both webs, the dorsal scarring is barely visible. And this is quite an early post-op picture. Again, for patient profile, the palmar flap will work for most patients, but if you have dark skin at the back and light palmar skin, then we also would use a dorsal flap, because otherwise you have the light palmar skin at the back of the hand and that doesn't look nice. That's just a very brief summary of what we do in our hospital, and it works for most syndactylies. Of course, the more complex one needs more complex procedures, as we've seen from Stephen earlier. And I'm also intrigued about more long-term results. I also agree the cost of the halo matrix is a bit of an issue in some areas. Having said that, in a country like ours, shorter operating time is also a cost factor, and that might have to be taken into account. So looking forward for the long-term results. Thank you.
Thank you. So last of all, Giele Arrowsmith, it's your turn.
So thank you all so much for doing the presentations. It's been absolutely fascinating. It's been great to have so many of my heroes on the screen. I think it's really interesting that we have such a range of approaches, and we've all got good reasons for making the choices that we've made. I moved towards a graftless technique because of my concern with pigmentation and hair development in grafts in the children that I'd learned from when I was a junior hand surgeon. And I've been very happy with it, apart from the dorsal scar over the finger. And I do agree that that is a permanent mark that we're leaving on these children. It would be really nice to avoid that. But I remember the long-term results of skin grafts being something that I thought I would not like to leave on a child as well. So I'm very interested to see long-term results of the dermal matrix, to see whether that provides a good cosmetic outcome and a low incidence of web creep. Taking split full thickness skin grafts to inset into syndactylies, I remember being a really long-winded, fiddly part of the operation, and I am glad that I don't have to do that routinely with my dorsal web flap.
Thank you all for your comments on the paper. So Chuck, I would like to invite you to start with for answering some of the questions that have been raised with regards to your paper, namely your follow-up, whether you have any longer term data that you haven't published but you would like to share, and also what your experience with ethnicity together with your experience with the healing time of these children are.
So thank you, and thanks for all the comments. I want to address the cost issue really briefly first. So in the United States, which I think notoriously is the most expensive provider of healthcare in the world, this small hyalomatrix package is around $300 US, which is not, you know, it's a real number, but the time saved in the OR by our math makes it cost effective. So that's number one. Number two, I do not have long-term experience because I haven't been doing it that long, and I'm not completely convinced, like all of you, that it is the answer. I still find great value in a full thickness skin graft. I also use the anticubital crease because the color match is excellent. And so I don't have long enough follow-up reliably to share with you and to suggest that it is either a good or a bad technique. Color match seems to work in the sense that we do not have change in color over time. But again, I don't have more than 4-year follow-up, 5-year at most maybe. And so I can't really comment on the long term. And lastly, healing time. So the healing time is super interesting, and it is completely fair to say that a full thickness skin graft is healed at 2 to 3 weeks max, with very rare exception. And the hyaline matrix may not be that predictable. There are certainly patients we see at that 3-week interval when we take the cast off who are done, but there are other patients, whether they have a reactive response or not, that can take a few additional weeks to truly be healed. And so that is a fair critique, but I'll challenge you this. If you offer any parent a chance to have this operation done without the harvest of a skin graft, they will all pick it. And whether that's a fair question to give to a parent or not, every single parent would choose hyaline if given that choice to save the harvest site, donor site for the skin graft.
Marybeth?
Marybeth?
Something that I didn't mention earlier was that I take my skin graft from the ulnar side of the wrist flexion crease because it's a perfect skin match. There's always enough there to do a simple syndactyly, and it never grows hair. So just for the other thing is that it's underneath the cast, and when the cast, and so it's protected, it's not moving, and it usually heals up beautifully. So thank you.
Stephen Hovius.
Thank you. I would like to make a plea for in terms of healing. We have been customized now to give a sort of boxer's bandage with a very slight little cast in it. I was taught that by Guy Fouché, and we leave it on for 6 weeks, even in the Apert syndromes. And you might think, oh, but they can infect it and you have to look at it all the time. It's psychologically better. And wound healing is very much better, and we've proved that with a group who we treated in the classic way with multiple sort of interventions, if you like, at the outpatient clinic to look at them. And I think that's another thing of wound healing. If you leave the wounds alone, they become very nice with grafts. And if you have to do a lot, for instance, with like the hyaromatrix, then you might have more chance of getting granulomatous wounds. Just I do agree with Chuck that if you can avoid grafts, that will be better for scarring, of course, and extra time and all that stuff. But the other part is that if you leave it healing, it will become very nice. And we didn't have much graft loss, even not in cases like Apert, where they have a different sebaceous gland and so on.
Jill, you had your hand up as well.
I was just going to say, I agree with Stephen in terms of healing, that the longer you leave it, the less likely you're going to have as much of a problem, because I must admit I haven't had the courage to leave them 6 weeks, but certainly trying to replace the dressing, you're never going to get it on as well as you did during the surgery. But my other thing is I take from just below the axilla. So Marybeth was saying from the hand, but mine's just below the axilla. You've got a good color match, and it doesn't notice if you've got a t-shirt unless you're like this. So, you know, if you get the little strappy tops and you do that, yes, but otherwise it's fine and doesn't really notice very much.
You do it again, Jill. I didn't see it right.
So that's another alternative that gives you a good color match, as long as you don't need a massive amount of skin.
Thank you. So I think we're now at the point of the evening where we're going to move on to some questions for the panel. So can we start off with a question from one of our dear colleagues here at Stoke Mandeville, Jeremy Rodrigues. He is a wonderful evidence-based plastic surgeon here, and he asks, is it true that full thickness skin grafts don't contract? There is evidence from skin cancer work of 38% secondary contracture by 111 days post-op. Would anybody like to comment on that?
Every normal wound, every normal skin will not contract. full thickness graft is not normal skin. It's better skin than a split thickness graft, but it's not normal skin. If you have the whole charade with everything on it, with fat and so on, it's much more pliable. So yes, there will be a slight contracture, but it'll be far less than in a split skin graft. So that's my comment.
And would you take that into consideration when you decide on the size of that graft? Would you?
Absolutely. I saw, for instance, Alain Gilbert taking off all the fat and making the skin sutures as tight as possible because he wanted thin fingers. And I went the other way around. I thought to make it quite not so tight together, to leave it quite so less tightened if you at the end of the operation, because you didn't want a graft, and rather leave it open or use a graft. And if you leave it open, you can go to the hyaluronic matrix. And if you go to the pulps and leave it a little bit open there, it will heal perfectly well, as we all know from the skin tip injuries. But if you go in the middle section and in the proximal section and really close it tight, you will really have a problem in hypertrophic scars. So I don't even think about not using a graft in those cases.
Right. Thank you. So we're going to move on. Question from Mary O'Brien from the Pulvertaft Hand Centre, directed primarily to Henk, but you're all welcome to comment, is indication for releasing syndactyly in feet, in children's feet. Do you release any syndactyly in feet, Henk, for aesthetic reasons, or do you feel that it also has a functional benefit to release them?
So clearly between the big toe and second toe, there's a functional benefit if you want to wear thongs. But between the other toes, I don't think there is much of a functional benefit. If it's a very tight, complex syndactyly, then there may be a functional benefit in terms of preventing deformity and contracture. But most of them are not like that. Most of them are simple. And then it's mainly a cosmetic issue. And if it bothers the parents or it bothers the child or later on a teenager or adult, then I will separate them.
Can I see a show of hands who would release a pediatric syndactyly in the foot, not the first web, routinely?
Not routinely, but I must say I have had 2 patients who weren't bothered about the look of it, but they had long second toes and they had a tight web, second web, and they developed pain when they went through growth spurts, which was directly related to the joint that was being flexed at that point. We released them and the pain improved. And these were children who really didn't have a worry about the way their feet were looking.
I might just add that I believe that the release of the first and second toes, so separating the great toe, is nice for wearing thongs or flip-flops, but it's more than that. I think that functionally is important for the way we walk and the push off of the great toe. And so I will release that, certainly the first and second toe, but I have not routinely released other toes. It just seems to be more problematic, and most families respond with reasonable conversation.
Right. And Stephane?
Yes, the most important is to explain to the parents it's just a cosmetic problem for the second to fourth web. And excluding the first web was very different. I explained that the child will be nice with a normal sport activities, or he can wear shoes normally, because they are very concerned about this. But if you explain that they have no functional impairment, they will accept. And then I say, I can do a better job when the child will be age 7 or 8. And at this moment, I know clearly that the child will give his advice and say no. So that's why I push the procedure far away. And then in my experience, I operate only very few teenagers, and only when they really push for the demand. And it's just a personal opinion of the child. And if they are really concerned with the appearance of their feet, because they have some teasing sometimes, okay, I will accept to separate the toes and perform the same procedure as in the hand with a dorsal flap and sometimes a full thickness skin graft. In some cases you can avoid, but okay. And for the full thickness skin graft, as said Stephen, they will retract, but it's an advantage. Maybe it's a good advantage to have a small retraction without any, of course, contracture on the plantar or palmar surface. But it's an advantage to have this small retraction because at the end, the surface of the full thickness skin graft is smaller after 6 months or 1 year, and it's better because it's hidden. It's more and more hidden with age.
Thank you. Another question from Dariusz Nikau, who is a plastic surgeon in London. He would like to know, do the authors assess abduction in desyndactylized fingers?
Meaning as part, I'm sorry, meaning as part of a study protocol where we look at how much abduction the fingers, I assume that's what the questioner wants to know. I actually have not found that to be an issue. We did try to measure that we did a study looking at complex syndactyly reconstruction and did not find that to be a limitation. Others may have had a different experience.
Thank you. Anybody else like to comment on that?
May I just ask the panel, in the same line of thinking, what about the rotation? How do they prevent rotation, especially when you have a distal fusion of the phalanxes?
So, Giele, did you find any rotation problem when you released the border digit, for example, in the case that you presented?
Not that I really noticed, but it's a bit difficult in him because he's got that odd middle phalanx anyway. So he does have a slight sort of angular deformity. I think that's really difficult. I don't know I've got a good answer for how to avoid rotation. I use small flaps, so I don't feel I'm dragging a big flap round the finger and contributing to rotation, but I don't know if that's a real thing or just a hope.
Do you think the tension contributes then?
Yeah, I think scar tension would contribute, yeah.
Giele Smith?
I think as far as the abduction's concerned, any scar that goes volarly across the web will restrict abduction. As Henk said, he had changed his technique so he could make sure he didn't get a straight line scar across the front of the leg. But I think Chuck has previously shown that in complex syndactyly, rotation deformity is almost normal, and he's looked at some long-term results.
Dariusz has come back with an addition to his question, asking about assessing abduction if you're comparing techniques using the Naranjan technique versus a full thickness graft. Is there anything, would any of the panel like to say anything about learning experiences or things that they found don't work well that cause problems with abduction?
Henk.
So for outcomes or research recording, I do measure abduction compared to the other side, unless they're both affected, or compared to the adjacent digits. And it's probably a feature if you have a very narrow web flap, or in techniques that don't use a web flap, but just do finger separation. And whereas Naranjan technique does use a dorsal flap, so there shouldn't be any issue, particularly with that compared to a full thickness skin graft and a dorsal rectangular flap. But I think, yes, you measure as much as you can to try and determine what the differences are. As far as rotation is concerned, some rotation is deformity that's because of the complex nature of the syndactyly, particularly at the tip, and when there's a length discrepancy. And even though you separate the digit, that may persist or become more apparent as the child grows. And in some severe cases, I have had to do derotation osteotomies when they've grown fully. But you've got to be careful when you're doing the flap inset that in your effort to close the defect, you don't create a rotatory deformity. So if you pull an apex of a zigzag flap to close the side of the digit and you close it, you pull it too tight, you can create a rotatory deformity. So you need to make sure, and if that's the case, then you need to let those stitches out, let the flap reseed and leave an open space, because you don't want to cause one.
Do you ever find the open spaces to be a problem, Henk?
No. So when I started, those open spaces bothered me. And I used to spend hours putting, 2 millimeter by 3 millimeter skin grafts on the side of the digits. And it was a complete waste of my life, because actually you don't need them. They'll heal up within 2 weeks.
Okay, great.
We've had a few questions coming in about Giele Arrowsmith's case and the decision to do that in 2 stages. So it will be interesting just to hear from other panel members. In fact, we've got a photograph that's been sent from Dr. Shen in China. Dr. Chen, we're just going to put that up on the screen to just get comments from members of the panel, what they think. She did this case in 1 stage. Can everybody see that?
So I think we lose all the panel members here. So can we invite Marybeth for her comments on this? Marybeth, you'll have to unmute.
Yes, I've just unmuted. So my feeling on that is that these fingers were formed in that mold by 8 weeks of gestation. So the maximum growth has already taken place. I don't think there's any huge hurry to get in there and untether the tips if you're waiting for the child to become just a little bit bigger, a little bit safer for anesthesia. So I don't think that you have to go in and stage those, because you're still going to be able to get everything accomplished. And that last little bit of growth, say 6 months to 9 to 12 months of age, is nothing compared to what that child's hand has already grown. And that's the argument that I give to the parents, to allow me to wait until the child's a little bit bigger and a little bit more mature for anesthesia. Does that answer the question?
I think it does, yes. So following on from that, Marybeth, I can ask, how many stages would you be comfortable to release more than 1 digit, maybe a more complicated syndactyly? Would you try to do them in 2 stages in total? So
I still don't like
the anesthetic time, or?
Well, I still don't like operating on both sides of the same finger at the same time. So if you have a complete syndactyly involving all of the fingers, then I would separate it into, I think this was the live long and prosper sign, wasn't it? And then later on and come back and do these 2. Or if it's 4 digits, or if it's just a little bit of a web, then sometimes I'll work on both sides of the finger at the same time. But it's a matter of kind of judgment right there.
Stephen?
Yes, well, I've been taught in probably the same way as Marybeth has been taught or has been doing her work, but I've been now for a very long time on missions in Indonesia, where we didn't have much time, and I didn't know if the children would come again a year after. And so then I started to do all the syndactylies at one time. And actually, I'm at the wooden table and I'm knocking on it, or I can knock on my head. I haven't lost a finger or something in those cases, even in some brachydactyly, which are rather flemish fingers sometimes. So I don't know anymore. That's what I'm going to say. Is it safer to do Marybeth's way of thinking? Of course it is. But is it possible? Yes, it is. And Henk has also done it in Apperton, and I followed that, and it's also possible, but that's a different ballgame.
Interested to know if Kirsten has any ideas Any thoughts on this subject? What's your view?
Yes, I have some ideas. I agree with Marybeth. I usually do a safer release and do 2 stages if more digits need to be released, and try not to use, if it's the whole finger, not to release it on both sides at the same time. Unless it's a partial syndactyly, then you can do it. But I'm pretty sure, as Stephen said, if you're carefully done, it's all what happens if you ever lose a finger, and what do you explain to the parents then? So I'm still trying to stay as safe as possible, and that's the principle I follow.
Stephane?
Yeah, just a comment on this, because it's really dangerous for our fellows to teach that we can separate all the webs at the same step. I've seen in Vietnam 2 cases where the children have lost the 4th finger because they had a simultaneous separation of the 3rd and 4th web, and they had the venous impairment, and they lost the 4th finger. So it's not a theoretical problem, it's a real problem. So I wouldn't dare to do this, and I tell my fellows, never try to separate 2 adjacent webs, really. I prefer to do 2 steps, 1st and 3rd, for example, and 2nd and 4th.
Henk, can we bring you in here as well, please?
Yes. So I try and do as much as possible in a single stage, but I hear the note of caution from others, and I think that's sage advice. So because there are theoretical problems and difficulties, but if you're aware of them and you're sensitive to them, it is possible to do a complex multi-digit syndactyly all in one sitting.
So Henk, based on that and your experience, have you encountered any vascular issues when you have released all the digits? Or do you have any tips on how to safely perform what you practice?
So I separate the digits from the dorsum because it's much easier to find the palmar digital arteries from the back rather than the palmar aspect as you separate down the mesenchymal plane between digits. And if I'm separating either side of the same digit, I will see where the vessel is, so that I'll always maintain a vessel with a digit. Now, sometimes that vessel will not extend the whole length of the digit, but it might go up to the middle phalanx or something. That's okay. So it's not, I'm not just blindly separating every digit, and I'm not dissecting the vessel out from the palmar aspect, because I think that causes injury and it's more difficult. But when you start the separation and pull the fingers apart from the dorsum, you can see the vessels easily.
Okay.
Marybeth?
Just one other comment. If you have complex syndactylies where the distal phalanges are joined, I'll separate the tips. So I'll do non-adjacent web spaces, but then separate the tip. And you can separate the tip down reasonably far, say to the middle portion of the middle phalanx. Now what you're dealing with later on is a simple incomplete syndactyly. And so that often gets you ahead of the game, even though you aren't doing the entire separation.
Great, thank you. So we've talked about the flaps, the graftless techniques and the grafted techniques, but one thing that was also different in Kirstin's talk was using the volar flap for web space reconstruction, and she demonstrated some beautiful results in her presentation. Giele talks about partial volar flap. Can I get Stephen Hovius's thoughts on the volar flap, please?
The only thought I have actually is not against palmar or dorsal, but maybe 2 thoughts. One, don't have a scar in the middle of the interdigital space. You might get a scar in the middle of the interdigital space when you use 2 triangular flaps which join each other right in the middle of the interdigital space. And the second point is, If you look at your hand, the slope comes from dorsal to ventral. It doesn't come from ventral to dorsal. Look at your own hands. And so that's 2 points to think of dorsal and to think of the fact that you don't want a scar in the middle of the interdigital space. That's all I would like to comment.
Bill.
Firstly, for the volar flap, don't use it in toes. It doesn't work. There's not enough pull through. So for anyone listening that's thinking about trying a volar flap, don't use it in toes. It can be quite nice. I routinely have a scar in the interdigital space, Stephen, but it seems to work very well. My predecessor did it for 20 odd years with good results as well. What it does avoid is any scar that's going to cross across the web space and get contracture. And as I say, usually I'm finding contractures very, very late. It's also an easy one to revise, because if they are like that and they pull out a little bit, you just advance them for the next revision. So that's worth thinking about as well, because it can be difficult revising some of these cases.
The major drawback of the dorsal flap is, of course, especially if you use wing kind of flaps, which I do and Henk does, and I've done it for years and years, is you might get visible dorsal scars. Of course, you get always dorsal scars, but I'm talking about visible dorsal scars, which is different than having a dorsal scar. And especially in hands, mostly scars are not that bad. But if you get a visible dorsal scar, then yes, then you have your drawback, and that is a big drawback if you get that.
Right. Chuck, can I ask you to comment as well? Or both Rebecca and I want to hear your thoughts.
On the volar flap?
Yes.
Yeah, Paul Mansky was my mentor, and then others actually, Marybeth and Stephen and others on this panel have been mentors to me. And I was never taught to use a volar flap. And so therefore I've always used a dorsal commissural flap, as in the picture I showed, that's originally described by Adrian Flatt. And I've been very happy with it. It does recreate that 45-degree dorsal to volar angulation, as Stephen just demonstrated. And for me, it's been a really good flap. And so I don't have anything negative to say about using a volar flap. I've just not had the need to use it, as I've been happy with what I've done.
Can we go on to another question? And we are getting to the end of the discussion now, but a question from Tommy Lindau for the faculty. Could you consider top 3 technical and strategical tips to be successful in simple and complex syndactyly, particularly for surgeons who are not protected by large congenital plastic surgery departments?
Maybe we can all give one.
Would you like to start?
Well, if I start, it'll be the easiest one.
Yeah, go for it.
Sure. I will start by echoing what I think Henk said earlier, which is do not feel the need to have perfect skin reapproximation throughout the digit. Leaving small gaps and defects is perfectly fine. And so I use large triangles and I repair the apex and perhaps one stitch in the middle, and that's it. So limit the number of sutures you place.
Thank you. Any other tips, Marybeth?
Patience and no tension.
It's getting harder, so who would like to go next? Henk put his hand up first.
Check the vascularity of your flaps and the finger before you dress it.
Kirsten?
Keep the dressing on as long as you can. Don't interfere with your postoperative result. It will heal quicker.
Giele?
Keep your technique simple and draw it once. Check it 3 times before you cut.
Stephane?
I do recommend to defat. Defatting is a very important step. That's why I'm concerned for the venous drainage, because I really defat until I reach the peri-tendon of the extensor. So it's maybe aggressive, but I think it's a clue to have a good take of the graft, because it's better to graft on the peri-tendon rather than on the fat tissue, the fat.
Giele Arrowsmith, any further comments?
I don't know. Gaps is better than one large gap.
Great. If I may, one of the comments on Chuck's paper was the length of the follow-up was limited. In the panel's opinion, when do you start to see issues with web creep or with revision? When do you normally see patients that require revision surgery? Is it years later? And therefore, how long do you follow your patients up for? Giele Smith.
Unless I've had infection or wound healing problems, I would expect it to be at their second major growth spurt at the age of 8. And that's if I've operated at 6 months or 1 year.
Yeah. Giele Arrowsmith.
Yeah, I'd echo that. I think I follow the kids up for quite a long time, and I think it's as they go through their major growth spurts, and I think it would be at least 5 years since your surgery, hopefully 8 to 10 years.
Stephen?
6 weeks, 1 year, 6 years, 12 years, 18 years.
Okay. Stephane?
Yeah.
Stephane, have you got any protocol for follow-up with your patients and when you see complications, if you see complications?
First opening of the bandage after 2 weeks, because I'm careful, but maybe I could leave it for 3 weeks probably. And then I follow them after 2 months to check if I have any contracture of the scar and to give some topics, for example, corticosteroid creams to improve the scars. And then at 6 months, 1 year, and every year, if patients are happy to come, I will encourage them to see them every year to see the child growing.
Marybeth, and your experience?
Well, the kid that you really have to look out for are the kids with big fingers. And I would warn those parents ahead of time that there's a very high likelihood they're going to have bad scars, including true keloids. And if I see one of those kids, I would probably take their dressings down at 2.5 weeks. Usually I keep the dressings on 3.5 to 4 weeks, but I would probably take those dressings down just to assess whether or not you're going to have normal skin healing. But that's one of the things you really have to watch out for. And then we encourage the kids to come back about, every year or two. And certainly if they were worried about anything, but try to follow them for as long as possible.
And what about you, Henk?
So yeah, I follow them up every year or second year to check, but particular time points to look out for, which may indicate surgery for social reasons, are the transition from primary to secondary school. So whenever that might be, depending on your schooling system, because a lot of parents would like to get any potential problems or real problems sorted out before that happens.
Giele Smith.
Just a comment about infection. If they have skin problems, or in my case, I had a patient who got chicken pox within the healing phase, then you will find that Koebner's phenomenon occurs and you'll get that skin problem or the chicken pox recurring in your scar, which will slow healing, and then you will have problems. So just be a bit wary. We don't immunize routinely over here, and so that is a concern. And obviously psoriasis and eczema are other similar concerns.
Okay, Rebecca, I think this will be the final question for the evening, and we would like to thank our amazing panelists for sharing their experience. As we talked about earlier, this is the best form of democracy where we share our thoughts across the world, and we hope that you all benefit from this. We are hoping to take out any sensitive material from tonight's talk, and this would be available through ICOPLAST or PLASTA. I'll let Rebecca clarify on that in the near future, where you can watch back and hopefully benefit from this in your own time as well. So thank you to all of our panel. There are further comments and questions that I'm sorry that we haven't had chance to, and that's because we've collected some of the world's best to give their thoughts, and it takes time to get everyone's thoughts on individual questions.
It's been a really great evening. Thank you, Dave. Very impressed that you managed to put this panel together from around the world with an international audience as well. So I really enjoyed it. Many thanks. Many thanks to my colleague James Chan for doing all of the rounding it up as well. It's been wonderful. Thank you. We'd like to, yeah.
Before you all go, we need to have a picture. So smile, 1, 2, 3. Perfect. We'll send it to you guys.
Many thanks. We just want to say one last thing. If anybody has any articles that they would like to make the subject of our future Phronesis evenings, please do get in touch. And we're going to just say that's via James Chan. And I'm going to just put his email address in the chat. If anybody has any papers of their own or anyone else's that they'd like to make the subject of this debate, then we can work to put towards a really good panel and a lively discussion. Thank you very much and enjoy the rest of your evenings.